Good morning. PC rent is an embarrassment, and Satyamurthy wants to make it large. Okay, so I'll be showing you a series of PC rents and how I went about managing them. Here you just see I'm doing my FACO, and oops, sorry, we skipped that, I think. There we are. I created the rent, and now it's very important to hold your FACO probe there and not panic. Inject viscoelastic. Before you go into bailout options, the first thing we need to learn is to teach ourselves to hold that FACO probe over there and not jerk it out as a part of the knee-jerk reaction. Inject viscoelastic, separate the fragments, assess the rent, how much damage is there, there's some vitreous or not, and could you possibly take out the fragments with your FACO probe. And then once the fragments, there is no risk of any fragments sinking, then you go ahead and do your vitrectomy and the other things that you want. Here now, once the fragments are out, you can assess how big your rent is, do a vitrectomy. Now what I do is I use this cutter itself to remove the cortical matter. Now there is a small issue over here. This does not work like your IA probe because the port size is slightly larger, so you need to engage more cortex when you want to pull it out. But this works very well because I can switch between the cutter and the aspiration. You can just work with the foot switch. Now I'm putting viscoelastic. I have a central rent. I find it to be round. I don't find the necessity to do a posterior capsular excess. And then I put in the lens in the bag. I've just put the optic in the bag, and the haptics are gently tucked in. See, once you have done a vitrectomy, the things like capsular contracture and all become less dangerous. So you've done a good vitrectomy. You can place, I place the trailing haptic also into the bag, and just to be sure, I just dial the lens a bit. Since the vitrectomy is done, this is much easier over here, and I've been following up this patient for I think nearly 5 years, and he's doing very well. Now this is an early PC rent. As I'm doing the FACO, slightly softish cataract. That's where you have the problems. It's like hot knife going through butter. There. I have actually created the PC rent over here, and it's doing very well. Now this is an early PC rent. As I'm doing the FACO, slightly softish cataract. That's where you have the problems. It's like hot knife going through butter. There. I have actually created the PC rent over here. I have a suspicion. I'm not very sure. So I go ahead and complete the FACO. Fortunately, this is a relatively soft cataract. I could do my job, making sure that my nuclear fragments are always away from the PC rent, and then remove the rest of the nucleus and epinucleus, whatever is there. I have a PC rent over here. I'm quite aware of it. Here is my PC rent. Now this is a spatula which I use sometimes just to give me more protection, so nothing drops in. Slightly wider spatula, second instrument. Now we inject viscoelastic and see on a higher magnification and assess the damage. Once we assess, we need to assess the damage to go in for damage control. Then take the vitrectomy cutter. Initially the cutter faces anteriorly, then you turn the cutter face downwards. Keep the cutter port away from the edge of the PC rent unless you really want to enlarge the PC rent, which we do in some cases. Like now I'm aspirating the cortex using the same cutter. Saves you the trouble of bringing instruments in and out of the eye. And then I can keep switching between cutter and aspiration with the same instrument. This is behind the plane of the PC rent that I was doing the vitrectomy. Make sure that there is nothing at the plane of the PC rent, no vitreous. Again, now inject viscoelastic. Now I think I was planning a multi-piece IOL over here, so inject viscoelastic under the iris, between the rim of the anterior capsule and the iris, to create space. Now I think I was planning a multi-piece IOL over here, so inject viscoelastic under the iris, between the rim of the anterior capsule and the iris, to create space for your leading haptic. All that you need to do is create space for your leading haptic, and the rest of the procedure just follows. The leading haptic goes gently into the sulcus, deliver the lens. You have an intact anterior capsular rhexis, there's nothing to worry. This lens is not going to drop anywhere, and definitely if you have an intact anterior capsular rhexis, we must do rhexis capture of the optic. That would just ensure centration. However sure you are that your sulcus diameter and IOL diameter matches, it's always better that you do a rhexis capture so you get this fusiform appearance. This is the appearance you get. That ensures centration for life. Now this is a bit of a controversial topic. I'll be doing a sulcus placed single piece foldable lens. I have done a few lenses over the last 2 years. I've been following them up. As soon as I have some more data, I will probably publish. It is controversial, so it's an off-label use. You may decide to adapt this procedure or trade cautiously. Now this is a PC lens that I had. Assess the rent, go into high magnification, take your time. Once you have injected viscoelastic, take your time, do the vitrectomy. Now this patient was scheduled for a hydrophobic single piece acrylic lens, so I chose not to alter my schedule. I got one more minute. Okay, so there I removed the cortex. In fact, I removed most of the posterior capsule during my vitrectomy deliberately. Now I am creating space in the sulcus. Most of the posterior capsule during my vitrectomy deliberately. Now I am creating space in the sulcus, just like I did for the multi-piece IOL. And this is a single piece hydrophobic IOL going to the sulcus. I must remind you, this is now generally if you leave this lens like this at this stage, you are going to have pigment dispersion, chafing and glaucoma. But I am ensuring that there is no vitreous anywhere. I am removing all the in fact I am working now behind the lens. I am doing the vitrectomy behind the lens, making sure and removing all the viscoelastic that I had put in. Now I come anterior to the lens. Now I am going to do a rhexis capture of the optic. This is essential. If you don't do this, you are asking for trouble. Once I've done this, I'm happy with the centration, and this is the post-op picture. I've been following up these patients. They are doing very well. So let's see how things go. Thank you for your kind attention.